CT coronary angiography in a Kawasaki disease. So I'll start with the case because that will make more memories. Because this case came from from Guwahati, and fever, maculopapular rash, redness of eyes and swelling around the left side of neck. Then fever was persisted in next week also, and then developed progressive generalized swelling with gradually worsening respiratory distress and admitted to another hospital. And he had developed hemorrhagic pericardial effusion, required mechanical ventilation, and at that time MIS-C was also a possibility, so COVID antibodies were done. But then echocardiography was done at 10 weeks. So at that time there were giant aneurysms and query thrombus was there. So when we had done echocardiography, there was giant aneurysms and thrombus was there, and these were the giant aneurysm in RCA, LAD. But what we can't see is that the extent of the aneurysms in the distal part and what are the severity beyond that. When we did CT coronary angiography at our hospital, which you can see is that these are the very horrible, like left circumflex, which we can't even see in that. There is hugely dilated LCX, and it's like an aneurysmal in the distal extents also. LAD, the aneurysm, there is one more aneurysm which is almost in contiguous of that. So there are multiple aneurysm to have. So echo basically underestimate but echo has given a fair idea that there are several issues, but still the true burden of the disease has not been picked on that echocardiography. So we all know that cardiovascular complications are the most important life-limiting or morbidity causing complication in Kawasaki disease, and these are coronary artery aneurysms, and if you don't treat that, 25% of patients will be at burden of this disease. So series of KDs are that coronary artery abnormalities can be form of aneurysms, ectasia, dilatation, stenosis, thrombosis. It can involve any segment of coronary artery, that is a problem, although it's more of proximal, but distal segments are also. And the precise identification is most important part, because that will be for the treatment stratification and severity and prognostication also. So echo is no doubt that is generally the preferred imaging, but however echo is not enough, which I have shown you, and there is no unanimity on ideal imaging modality for long-term follow-up. That is a problem. So what we have in our imaging armamentarium is that echo, coronary, that conventional cath angiography, and MRCA and CTCA. So why we are talking of CTCA is that echo is the standard of care, but we can't see middle and distal segments. The complications and thrombus and stenosis are difficult to see, and it's operator dependent, and although we can do more frequently, but still these are the issue. Then the cath angio is gold standard, still remains a gold standard, but it's an invasive, inordinate radiation exposure and cannot be repeated often because you can't do many times. MRCA is definitely a imaging of choice if you can do like whatever you want to do, but the problem is that long acquisition times, and in small children you can't perform that, and its temporal and spatial resolutions are. So therefore we have a CT coronary angiography, and CTCA is a non-invasive, and in the current standard high resolution CT scanners, which we can also control the radiation exposure also, and what we have shown is that radiation exposure is within acceptable limit, that is less than 1 millisieverts, and if you can compare an X-ray chest is almost 0.1 millisieverts and is almost a 10 X-ray, so which is not very high, but because in children we are more concerned with radiation exposure, and there is an excellent correlation with measurement on echo and angiography. You must have seen Dr. Suda has just shown in previous talk that how she has compared with the CAG and CT angiography diameters, and which is almost incomparable. So CTC has a potential to become the standard of care for diagnostic evaluation and CA in children where it's applicable. So what we have seen is that over the years we have seen that coronary artery abnormalities in prevalence has increased in our cohort. So in 1994 to 2004 it was around 5%, but it has risen to around 16%, and there are several reasons for that. Possibly we other part of the India has also seen, because Professor Penkapal has also seen that the coronary artery abnormalities prevalence in their cohort is also. But one of the factor is that the increase imaging modalities, because echo we can do more frequently nowadays, and then CT coronary angiography has also changed our the way we are treating and we are managing these patients. We can identify more and more aneurysms in these patients, and you can see then follow-up also. So it's an amazing paradigm in the Kawasaki disease, and it's thanks to the Professor Singhal, because of him we can do these CT coronary angiography, and the one more important part is that whenever we are doing CT coronary angiography, the radiologist should be there, because and he will be there at each and every CT scan. Because you have to optimize radiation, you have, like in children, we can't compromise about the radiation exposure. So the CT coronary angiography is the way forward, and what we have shown in our experience also, that distal coronary angiographies distal CTCAs are there. It may be that they are in isolation also sometimes, and if you don't do CT coronary angiography, you will completely missing these patients. And in one study, what we have seen is that, because it's always a concerns that whenever we don't treat Kawasaki disease, that is a spontaneous defervescence, what happens to them in a long run? So echocardiography is the good, but what we have done is that after a mean follow-up of 3.8 years in children with Kawasaki disease, we performed CT coronary angiography, and there was no coronary artery abnormalities, and even calcification was not there. So that is a reassuring also, that if whatever we are doing in a clinical science in KD with spontaneous defervescence, which we have almost 5 to 10% of children, we may not be able to treat because they are coming late, or possibly it's a milder form of disease, or when they are reaching that already they are in defervescence. So if there is no coronary artery abnormalities on echocardiography, and the inflammatory markers are normal, possibly we are much comfortable now that based on these findings that possibly we are doing right. So this paper has already been shown by Supreet, that this is in a proposed algorithm as distal as per the requirement, and then why we require CT coronary angiography is because of this also, possibly because left circumflex is hardly we can see, and we had a 1 hour session today in hands-on also, and everybody was convinced that it's difficult to see LCX, and because of several reasons, and so 2D echo is inadequate in identifying LCX. And why? Like, because although it's a left circumflex is not so frequently involved, but sometimes it can be involved in the isolation also, and at that time, because if you don't pick these coronary artery aneurysms, possibly you will miss them, and you will be able to stop the aspirin. But here, if there is a coronary artery abnormalities in LCX, you have to continue these patients on aspirin. We can do calcium scoring also in follow-up, and the study from the Jane Burns group has suggested that most patients will develop calcification after 10 years, but recently we have shown that it can develop very early in the within 1 year also. So, but if the patient has not developed calcification after 10 years, possibly you are comfortable in saying that possibly they may not develop after 10 years. It's required in a mandate follow-up also, because you may see the remodeling of this, and in remodeling of the coronary artery aneurysm. So to summarize, it's a non-invasive and daycare procedure, because we can perform whenever a child who is like whenever it comes to a daycare in morning at 9 a.m. and we perform the procedure by 11 a.m. and he will go with a report at 12 p.m. and cuts to Professor Manful Singhal. It's a luxury that we can have in 4 hours a procedure with a report in hand. So that can be done, and it's a superior imaging of entire coronary arteries, including distal segment and left circumflex, and it detects mural abnormalities also, thrombosis, stenosis, and calcification, which are missed. And the radiation exposure we have been able to optimize. What we can see is that infants, the radiation exposure is almost less than 0.5 millisieverts in most of the infants, and in older children it's around 1 millisieverts, which is also acceptable, and it can be useful for acute, convalescent, and long-term monitoring, and it's increasingly becoming the preferred imaging modality. And we have seen in latest update of 2024 American Heart Association, and they are also comfortable in saying that CT coronary angiography is possibly a way forward in evaluating the coronary artery abnormalities in children with KD, and it reduces the need for invasive CCA, which is very important, because if you like nowadays the indication for catheter coronary angiography is that when you want to do anything, you want to operate or you want to intervene, then only go for a catheter angiography. Otherwise, you just do a CTCA. Based on that, if there is a stenotic lesions or not, that go for a perfusion imaging. And then if there is you want to intervene, then only go for a catheter angiography. Thank you.
Thank you, Rakesh. So we have discussed when to do it and